Hello.
Hi, Lynn Goldman.
Hi, how are you doing?
We're doing well. How are you?
Yeah, doing well.
Fine. It looks like we have about 20. I think we can wait another minute or so to see. It took me a couple of minutes to actually get online, and I know sometimes there's a little delays and these WebEx meetings getting started because of that. So let's give it a minute or so.
Okay.
Okay, I think I'm going to go ahead and get us started. Good morning, everybody. If it's morning where you are around the world, it could be that our community could be anywhere, actually. I'm Lynn Goldman, Dean of the Milken Institute School of Public Health, and this is our kind of weekly, not always weekly, webinar about the COVID-19 pandemic. And today we have a very special panel of guests who are with us, who are two of our alumni who both work for the DC Department of Health. And so we have with us Matt McCarroll, who got his MS, I'm guessing in microbiology and emerging infectious diseases, MS degree in epidemiology. Matt is Chief of Laboratory Operations for the DC, I'm guessing it's the forensics lab that you're with, Matt. It doesn't say that very clearly to me, but you can tell us more about it. Go ahead.
Yes, so both Nia and I, we work at so we're in the Department of Forensic Sciences, but we work for the Public Health Laboratory. So the city has put all laboratories in the same building.
Right. They decided to go for kind of one of these kind of a matrix structure where the public health lab is in forensic sciences, but works in a matrix way with all the rest of the community. And he is supervising the overall COVID-19 workflow, I'm told. We also have with us Nia Deot, is that right?
Yeah. Yep.
Yeah. Who also has her MS from 2018. I'm pleased that I got to grant both of you your degrees from 2018. And she works as Laboratory and Epidemiology Coordinator for DC's COVID-19 response team. So I know that you're each prepared to give us a little bit of a description of what you've been doing, but I can tell you a couple of things that are front and forward on my mind. And one of which is ever since, I would say, like something like the second week in February, I mean, my life, just as Dean of the School of Public Health, has been nonstop COVID-19, and particularly things were very intense. I would say through maybe first or second week in April, and when things started settling down a little bit, but I didn't even notice that they were changing because by that point in time, I was so wound up that there was like a delay in even figuring out that, well, wait a minute, things are a little more under control now. And I'm sure you've seen that in your own jobs, but really what that was like for you being, working so hard, probably day and night, 7 days a week from what I'm sure it would have been. But also for me, a lot of this has brought home some of the very basic concepts that we teach in, the very first week practically of epidemiology around testing and the sensitivity and specificity of tests, the interpretation of lab tests, as well as our very basic instruction around surveillance and tracking and how we do that well, how one responds to results of testing in terms of getting back to the individual, to physicians, but also producing statistics for a community. And in this particular case, the pressure that has been on the DC Department of Health to turn those statistics around within hours, rather than it's usually weeks, months of time that people have to clean the data, to recheck the data, how you've been able to be on top of the workflow in terms of not only making sure that the tests are happening and that they're being done properly and that you have the adequate sensitivity and specificity, that you're meeting the requirements, but then turning around that feedback, whether it's to individuals, the medical community, or the world at large, because the whole world really cares about DC's rates of COVID-19, not just your patients, these samples you've got, but everybody in the world. It's in the newspaper all the time. And so I don't know which of you would like to go first. If I should ask perhaps Matt to start, and then let Nia tell us about her experience. And then we're going to try to have some time for some Q&A from the audience. I will say to the audience that we have a chat window. And if you have any questions or comments, you can put them in the window. I'm going to try to monitor that and make sure that we kind of address your questions. But so take it, Matt.
Thank you, Dean Goldman, and thanks for inviting us today. We're very excited to talk to everyone about what DC is doing. So as you mentioned, I am the Chief Laboratory Operations at the DC Public Health Laboratory, and that involves right now the looking over the workflow of testing. And when you talk about, how we've changed our lifestyles to deal with COVID-19, it's been quite dramatic. So I can remember, as you're saying, in the beginning of March, I was actually at a leadership conference with the Association of Public Health Laboratories with some other laboratorians from all over the country. And we're just talking about getting prepared and what we're doing, getting the CDC assay on board, and which states had positives, which did not. At that time, DC did not have any positives. And then I got back, and a week later, we had our first positive, and everything started spiraling from then. I went from working a normal 9-to-5 job Monday through Friday to now working a 8-to-8 job, going home, working again until 11 or midnight every night, just answering emails and organizing and developing protocols to be sure that we're on target. And we work 7 days a week, answering phone calls and preparing. And it was probably towards the end of March when we started our drive-through testing, which was a lot of preparation and planning to get that on board, bringing on Microsoft to help with the data collection, the data analysis. And then, since then, moving forward, it hasn't really slowed down for us. We maybe had like a week where it was slow, and then everything picks up again. And now we're moving to screening homeless shelters and nursing homes, long-term care facilities, prisons, St. Elizabeth's Hospital, to be sure that, to see at what level the infection has spread in those locations where people can't leave. They're actually confined to that location or that facility, and taking care of them. And now, as we look forward, we're looking into bringing on IgG antibody testing and starting a seroprevalence study, hopefully within the next couple of weeks. So it's very fast-paced. We have meetings all the time, just and preparing for testing, mass screening happens very quickly, and we just have to be flexible and be able to adapt to all of the numerous requests that we're getting from the city. So it's been very exciting, but also a little bit of exhausting at the same time. Nia?
Yeah, I can kind of talk more on the data aspect. So basically, we've always had surveillance systems kind of put into place where it came for like routine surveillance of looking at it. And so when this outbreak kind of started with the data, we had to create an entirely new system that can just basically take in all this data coming from all these various aspects, whether it's a commercial laboratory, our laboratory, and kind of turn it into meaningful data and basically for public health intervention. And so I kind of started off with slowly starting to track the data, and those commercial laboratories went live and we were getting hundreds on hundreds of data sets. And so I kind of worked with DC Health to make sure like we were reporting correctly. And like you said, you need the numbers right away, like within a few hours. So that's kind of like where I started. And then my job kind of is between DC Health and this public health laboratory. And I kind of work with also all the facilities outside of hospitals, like for example, group homes. And a lot of these places weren't used to this. They weren't used to having to worry about their residents being at home, and like they can't take them to hospitals because that's also exposing them. And so I kind of been working to create mobile testing so that we can take basically the tests to them, so they would have the ability to get the proper basically testing and treatment needed without exposing them potentially to COVID outside of that. So although this response seems like it's slowing down for some people, it's not over here because we're constantly being inundated with more testing, and more access to testing also means more data. And so that's kind of a lot of what I've been working with, is kind of ensuring that the data is clean and making sure that these vulnerable populations are getting the appropriate testing.
Thank you for that. So, one thing that I've personally been curious about, I will never forget March 7th, which is the day that the mayor announced the first positive case in DC. And I think there was also that day a positive in Montgomery County. And of course, one of the really important things about the DC case is that that was an individual who had not gone to Wuhan, China, or anywhere else, so obviously had acquired the infection in the community. And I think I knew, I'm sure you guys knew that of course there was transmission occurring in the community. We knew that for certainty because of what was going on in New York and all of the people that travel up and down the Acela corridor. I mean, of course, but I got the notice, that the mayor was going to hold the press conference at a certain time, and I tuned in, as many other people did, and I believe it was like an hour and 20 minutes before she actually showed up. So we're all going, "What's going on? What's going on? What's going on?" Right? But how that played out for you in terms of, just the political consequence to the mayor of having to announce this, the need to be 100% certain that it's true when the conventional wisdom was, well, you were getting it from Wuhan. It wasn't being transmitted in DC. There were probably a lot of people who really didn't want to. I mean, I came into that, I would say, with kind of a bias toward it is transmitting here. It's just a matter of minutes to hours to days before we have cases. But I know many people didn't believe that. I mean, that was the time you couldn't even get a test unless you would travel to Wuhan.
Yeah.
You had to have a cough and a fever and have been in Wuhan, which is, pretty narrow subset of the people in the US who actually end up getting the disease when it comes down to it. So, but what was that like on your end? I've worked in public health. I worked for the state of California in public health, and I managed crises like this. But maybe you can talk a little bit about that, from the standpoint of being the scientists, being the experts. You are producing a piece of information that is not necessarily what's wanted by everybody right at that moment, and how that was for you and how you handled that, what you learned from that.
Yeah. So you bring up a good point that, there is a lot of political pressure, especially when they're talking about COVID and all of the press that it was getting back then from all of the different press locations like CNN and Fox and everywhere. So there's a lot of pressure to be sure that you are accurate. However, it's important to remember that when we bring on a test to perform the test for SARS-CoV-2, we go through a very rigid validation process where we are testing 40 samples. 20 of them are known to be positive, 20 are known to be negative. We're confirming that we get the exact result that we're supposed to get, and the CDC supplies this proficiency test for us. We're training our staff appropriately, passing them through a competency test. And so at the end, when we actually put this test online and are ready to test patient samples, we are very confident with the results that we are supplying. And so, once we got that result and we saw it as a positive, we had our chiefs, our PhDs, review the results, confirm that it did actually, it was a PCR test. They looked at the CT value. They confirmed that the controls, the positive control and the negative control, worked appropriately, and we were confident with supplying that result to the Department of Health and to the mayor so that they could then go out and tell the community that we do have our first positive, and there will be some public health prevention measures that will be taking place. So we were very confident in the results that we were giving, also knowing that there were going to be a lot more added pressure going forward and a lot more tests that we had to prepare for.
I remember where I was when that first positive came and I heard about it from our laboratory. It's kind of on the DC Health side too. I remember I was with my DC Health colleague when the positive came out, and it was just like a quick, we need to get to the office, we need to get a plan out, and we need to figure out moving forward, because if this is one case, I mean, it's going to spread, unfortunately, especially because it was someone that didn't travel to Wuhan, like you said, and we were very, very concerned that, like, if it was already in the community, how many people had gotten it. So it was a very quick turnaround on just being able to respond and creating a plan to implement.
Well, and by the way, I don't think it's a secret, it's been in the paper, a minister, you can't contact trace an entire congregation, or did you try to? I mean, at what point in time did DC just decide that it couldn't contact trace all of the cases that were coming through? I remember with our own students that at first when we had and staff, when there were positives or suspected positives, that there were real efforts to do the epidemiology, and that at some point in time there were just too many. And now we're going back into a mode of, having suppress the epidemic, bringing on more people, to do testing and contact tracing, to really have the ability to try to put perimeters, if you may, around people who are positive to isolate them and prevent spread. But at that point in time, it was just spreading. It was invisible. It was, not possible. But, at what point did that happen in your view?
So we kind of were following CDC's guideline on that. Essentially, basically, when it first happened, we did do the appropriate contact tracing. But once it kind of hit the point where CDC widened the guidelines basically on who can get tested, and when you have an increase in testing, you can't contact trace all those people. And so basically when CDC was like, okay, we're going to open up kind of for health departments to kind of make the calls, that was when we were like, we need to make guidelines on what we can and can't contact trace. And that's kind of when we moved over to contact tracing, for example, schools and healthcare providers, and basically following CDC guidelines on that.
Yeah. So, I mean, some of the things I'm hearing, I mean, certainly Matt, having gotten the fundamentals right in terms of being sure that the testing that you're doing is validated and that you have checks on it so that you can produce a result that you're confident in, just how important that is when you're dealing with something that's of the magnitude of the kinds of decisions that the mayor had to make on the basis, even if just that one individual, one case.
Absolutely. Yeah. And I think it's also important for the patient when they receive their result, because of the press that COVID is getting. It's almost to the point where if somebody receives a result and says they're positive, especially during the beginning, they were thinking it was very serious. Is it a death threat? Am I going to die? I have COVID-19. What's going to happen? And so we had to be completely confident in what that result was and work with the doctors to provide those results to the doctors, who then talk to the patients. And it is important to continue to validate our tests. And we've expanded to new tests, which are more sensitive and have a higher throughput. And so it has allowed us to expand our actual testing capacity here at the laboratory. So we're able to test our capacity 500 samples per day currently, which we have gone over once. We tested 583 samples one day. That was a big day because there was, a mass screening event and a drive-through event and a number of other samples being sent to us. So, and actually, as everyone is getting ready for the city to open, hopefully June 8th, we are actually gearing up and testing more samples than ever before. So just last week, from Monday to Friday, we tested 2,500 samples, provided 2,500 results, and it's mostly, as Nia said, that as they relax the restrictions on who can get tested, it is now basically up to a physician. If a physician thinks you can get tested, you can get tested, regardless of whether you're showing symptoms or not. So anyone is allowed to get tested. So we're testing more and more people, and we're actually seeing a decrease in the percent positivity of the samples that we're getting. So in March and April, it was somewhere around between 30 and 40% positivity rate, and now it's lower, between 15 and 25%.
I mean, which of course is expected as you add in more asymptomatic people.
Absolutely.
Then, of course, fewer of them are going to be positive than those with symptoms. And so all along, we would have had, I think, a lower positivity rate if we had had the capacity to do a lot more testing, which of course we did not, which is not, your fault. And one of the things we hear a lot about in the press that I'm finding people are very, very confused about, and it's another thing, it goes back again to my first point, but this issue about false positives and false negatives. And every day it seems like there's a headline about, some test from China that's turned out to not be very good, or a commercial testing kit that some of the hospitals and big medical practices are using that maybe has a lot of false positives, quote unquote, or a lot of false negatives. And then a perception that I'm starting to get that all the testing has this problem. It's just been interesting for me that as people in the public are beginning to get these epidemiological concepts, that, I mean, some of them are taking hold. I actually heard a congressman explain R on a conference call. In a town hall meeting, a conference call to members of his community. He did an outstanding job. I want to put him in the classroom in front of my first year students. And I mean, whoever would have even, a member of Congress would even cared what R was before this, right? But the probabilistic concepts are particularly hard for people to understand. And then also the fact that there isn't like one the test. So people read these things and go, isn't it true that test has a lot? And so, how does that, because certainly the tests that you guys are using do have some percentage, of false positives and false negatives. And the more people that you're testing, the more of a problem that becomes, right, in terms of that small proportion of false positives for the virus, bringing in more people who don't actually have the virus, but who, are how you're handling that. But also you're going to start to do seroprevalence. There are going to be some people who come in who have a false negative for seroprevalence, yet they've had it. They know they've had it. There are going to be some people who come in and if you're, I don't even know if you're returning the results to them after the seroprevalence surveys, but we don't want them to think that that means they're protected from COVID infection, because the antibodies that we're measuring currently, we don't know if they are the antibodies that inactivate the virus, that neutralize the virus, right? And even if those were the antibodies that do that, we don't know if the levels are high enough. We don't know which levels we need to have, even of the inactivating antibodies. So, I mean, how do you work this into your consideration, for, either designing these studies and and how you're reporting these results and how you're communicating to your decision makers in the department.
Yeah, I can speak to the testing, and then I'll let Nia talk about how we're reporting the results. So as you said, there are a lot of questions out there of sensitivity, and people always speak to this test or that test. And really, what we need to look at is FDA is approving, a bunch of EUA, so emergency action utilization of tests, and so they have a long list of tests that have been approved for clinical and diagnostic testing, all of which have gone through a rigorous validation by the vendor or the company, and then a state public health laboratory can choose one that they want to use and do another validation to confirm the sensitivity and specificity of that test. And so I think it is actually more of a question of when people say, oh, I got false negative or I got false positive, I don't think this is true, like what test is actually being performed, and was this test actually an EUA? Because especially with antibody and IgG testing, there are a lot of tests that vendors and companies from China and South Korea are saying, here, use this, but it hasn't actually gotten an EUA approval from the FDA. So it's not a validated test that can be used by a public health laboratory. And so it's very important that we focus on the test that's being used and being sure that it has been validated and is appropriate to give that diagnostic information to the physicians who pass it on to the patients.
I think it's also, Epi 101 was no test is ever going to be 100% sensitive and specific. It's not. So, like Matt said, we go through various validation processes to make sure internally that it is working well and that we are reporting appropriate results. As far as reporting goes, at least at the public health laboratory, you have to have an MPI number to be ordering these tests, which means that you are a healthcare provider. And so we will report the results back to the healthcare provider, and that's under the assumption that they do know how to properly take care of patients. And so that's kind of what we're doing right now. It's just we report back, and if they do have an MPI number and they can take care of the patients, to be able to report essentially the information and the disclaimers that come with it. And we would hope to let them know that we don't know enough about the virus and the long-term immunology of it, and we don't know if you're actually protective if you're positive for IgG, So I think it's really just the knowledge and communications that are happening between the healthcare provider and the patient.
Right. And especially as we go into serology testing, I think the bigger issue involved here is there are actual coronaviruses that are routine and common in America and have been around forever, and it just gives you a common cold. And there may be some cross-reactivity in the antibody testing, which we have not completely seen yet as we continue to learn more about the novel coronavirus that we're looking at, SARS-CoV-2. So it's another factor to keep an eye on, and to always remember in the back of your mind that coronavirus has been disseminating through the populations for many eons, and it usually just causes a simple cold or maybe flu-like symptoms, but it has not been as serious as SARS-CoV-2 or the novel coronavirus that we're seeing now. And we'll have to see how the antibodies, how effective they are.
Those 4 coronaviruses that cause the cold, our immunity to them is fairly short term, right? Just 1 or 2 years. So it's not like getting rubella and being immune for the rest of your life nearly. It is just transient. And there's just a lot of myth about the ability to develop herd immunity on the basis of everybody getting this infection once, which is not really well substantiated by what we can infer from other coronaviruses. And of course, we have no facts about this one since it's only been with us since November. How would we know? But it's that's also been interesting.
That's a good point. And I liken it to when we had the Zika outbreak, there was some herd immunity that eventually developed, but it seems as though we have immunity. Well, if you get it, Zika, then you would have immunity forever, whereas coronavirus, it does not seem to be that way as we use the 4 coronaviruses that spread as a model. It's very short-term immunity from the antibodies.
Yeah, and I think that's why it's really important that people are aware of what it means to be IgG positive, and the fact that we're not going to know for a while how long this immunity is really around for.
So I have a question on the chat window, a really hard one actually, but I think it's interesting that I don't think in DC we have this problem, and maybe we do, but around the country, there are people who believe that hospitals have artificially inflated the numbers of COVID-19 patients, or that public health has artificially inflated them. And I mean, the question being how we discuss that. Maybe some of us have family members like that are grouchy, and I mean, I'm grouchy about the stay-at-home order. Everybody's grouchy about staying at home, right? But on that basis, to develop a conspiracy theory, maybe all of us have some uncle who does that. What do we say? What do we say? How do we explain this to people who think that maybe this is a conspiracy? Maybe these numbers are inflated. And yeah, to Jana, yeah, I know their earlier questions. I'm kind of taking them in the order that I. But go ahead. Which, if you want to go first.
I mean, I think it's hard to it's real, and there's no, at least from my end of when we're doing data, we're not just doing data in the sense of it's a positive. We're not looking into what it is. I mean, we're getting reports from hospitals, and we also get them from the commercial laboratories. And together we're cultivating data that's real. And I'm not really sure what to say to people with conspiracy theories, because it's out there. And I know for DC especially that we're taking the data and we're turning it into incidence prevalence and really getting to know what's going on in this district.
Right. And I would say, I think a lot of that has to do, again, with the large media pressure that everyone is seeing, especially when you're, isolated in your home and all you can do is watch CNN 24 hours a day, and it gets gets into your head a little bit, and that can be one point of view is what you're getting, but another point of view is to look at how we, as Nia said, we are receiving the data from the private laboratories, from the hospitals, and then from ourselves, and putting that together to provide a clearer picture for the mayor, and using science to put that data together to provide to the mayor, who can then work with her advisors to make suggestions or decisions for the community. Because the key point is for public health aspect, we're here to look at the overall health of the community, so of the entire District of Columbia, and that's the whole vision behind and point behind public health is protecting the public's health and not just one single person's health. So it's important to gather all the data. And
I'm sure it's not just here, but there's a lot of checks and balances in place to ensure that there's not misleading information. I mean, we want to open up the country just as much as the other people, but we want to do it in the most safe way possible. And so that's why it's really important that we are gathering the data. And if that means we have to slow it down a little bit, we're going to do that. But it's all to protect. That's what we came into public health for, right? It's to protect the population.
Yep.
And so that's what we're doing.
Okay, so I'm going to say that the answer is that these are honest folks who, they call this, they see it, the strikes and the balls, the fouls, anyway, and they're checks. So we have a question that is maybe not just about DC, but it's certainly in DC. How do people find out where to go get testing?
Coronavirus.dc.gov. On the testing tab, it will give you multiple locations and phone numbers to make an appointment to call. We have two, I know one of UMC and UDC, which is set up by DC Health. And I know there's places such as Sibley and Washington Hospital Center and a few others that also are providing drive-through and walk-up testing.
Yeah, and as we go forward, the mayor is looking to open up community testing, where we go to neighborhoods. So we went to our first community testing last Saturday at a neighborhood up in Brightwood, and we tested 281 people, and it was just people in an apartment complex. The mayor's advisor or volunteers were there. They called people down to do testing. You didn't have to pre-register. You just showed up. We tested you, and then results were being given back by DC Health Nurse Triage Center. And so we're going to continue to offer that throughout the next couple of weeks. And all of that information, as Nia said, is on the coronavirus.dc.gov website.
And there was a question, how many of them are there? And I think that's such a moving target. Do you have the number of testing sites in your head, or every time I look, there's more?
There's always more. I think on the website they list 12. However, those are just the ones that we know about. And as Nia can talk about, there are always locations that are popping up that we do not know about, which may or may not be certified by DC Health.
Yeah, there are definitely been places in DC that kind of just pop up with stands, and I would not suggest going to those because a lot of them we have to shut down because there's no regulations. They haven't gone through the proper processes. So just make sure that when you are going to a testing site that it is legit, which you can find on the coronavirus.dc.gov website.
And I should say there is one at the MFA. They have a drive-through.
Yeah.
I think it's only a couple of days a week. And I do think for most of them, they want you to call first, not just show up. There's a phone number that you call for each site. And I do encourage people. I get emails or phone calls sometimes from people who think they have, the coronavirus. And I'm like, one, call your own doctor, not your dean, but even though I am. But also that they can call and arrange to go and get the test, and there's no harm done in doing that. And I think it's an important component of dealing with the pandemic, that we're all doing that if we have symptoms and we think we might have the disease, to just get it checked out, because then we have the option to isolate ourselves and not be part of spreading it. And
I think an ongoing issue kind of has been is because of the bad media, it's just the stigma of having coronavirus. A lot of people are scared. They don't know what it means. And like you said, if you think you have coronavirus, there's no harm in getting tested. You can properly get treated and get what you need. But unfortunately, because of all the media coverage and the stigma that's come with it, I think there's a little bit of a fear to get tested now.
Well, I think, when we're looking, ahead toward fall, and we're talking about doing a massive amount of testing on our campus. And if you were still students, you'd be involved in that. But we really are feeling that the density of the campus population, especially those in the dorms, we have to take steps like that. It's a little different than being free living in the community. And we will be requiring masks. It's going to be a completely different way of doing our work, more online study, uncluttering, the classrooms. It's going to be very different. And I think that's true, in the society as a whole. Have things changed in the way that you work in your jobs, in forensics and public health? How has that changed the actual workplace itself? In DC?
So the actual workplace has just changed with the number of hours that we've done, as well as the number of contractors we had to bring in. So the DC Public Health Laboratory is one of the smallest public health laboratories in the country. Before COVID-19, we had about 30 people. Now that we're in COVID-19 and we're doing so much testing and there's so many different places we have to go to support testing, we now have upwards of 50 to 60 people. So we had to bring in a lot of contractors to help. So there's a lot more people here assisting with us. And as I said, the hours have increased greatly. We have also everyone in public health lab is now fit tested for an N95. So we've gone through the fit testing. And if you go to an off-site location, we recommend that you wear your N95 mask to serve as protection.
We've also kind of limited also how many people can be in rooms here. All of our all hands meeting now, our webinars, anything over 6 people, and we can't spread out social distance, we have to do it through a webinar. So it's how we interact with one another, which has been interesting because we are essential employees. So it's been almost people are at home. We have to kind of find caveats here to be able to basically do what we're preaching.
No, I remember when I started seeing LaQuandra wearing a mask. So do you think that that the response has led to innovations in how you do what you do that may have a long time impact on the work? Whether it's how you do the lab work, how you do the epidemiology and surveillance, using more webinars, using more online meetings, what do you see as innovations that may actually change things for the better in the long run?
Well, I mean, I think this entire pandemic kind of also just has changed the way we think about public health. I feel like it kind of broke down the infrastructure for us to build it back up. And it was just something that, like you said, not a lot of people knew about. And now you're hearing people talk about R and all of these things. So, and I don't think this is going to be our last pandemic. I think by the way that things are going and as we go into new territories of deforestation and interacting with animals that we never interacted with, like there are chances that it's going to happen again. So I think this is a good time to start kind of innovating and thinking of different ways that we can deal with a pandemic in the future, whether it's building our healthcare systems or it's just making sure that we have checks and balances in place, because isolation and quarantine is a good way to basically help stop spread, but we should be beyond that. We should be at a point where when something happens in a different country, we have the means to be able to quickly detect it and be able to act on it. And I mean, we kind of got lucky that started in China versus Chad, which has what, 3.5 doctors for 100,000 people. So it's kind of just now working to be innovative to create a public health infrastructure that this doesn't happen again, that we're prepared for it.
I mean, that was actually, Nia, the last stage of even, the White House, the stages, the last stage, it's not back to normal. It's not back to the way things were. We're preparing for them. And I think that's an incredibly important message that, this idea that we're just going to go back to the way things were is not reasonable. Matt, what would you add to that?
I think Nia said that very eloquently, and I would just add that I think we have a lot of the resources we're using, so a lot of the technology we're using now is going to be very helpful going forward. So one of the technologies that we started using in the Public Health Lab is a web portal for physicians to order tests, and allows them to order electronically, and then we can provide the result back to them electronically, which before COVID-19, it was all paper-based and we're faxing reports back to them. So this is definitely an upgrade, and we're very excited to be able to use this.
Moving forward,
yes.
Pushing public health forward.
Exactly.
I want to get my results back on this thing.
So we have that for drive-through testing. They do have it uses the Microsoft app where results get emailed back to the patient.
Really great. It's really great. So, it's always hard for a dean to ask this question, but it's also an important question for a dean to ask. And so when you think about what you learned in your program, and then the challenges that you have been facing at work, not just with COVID pandemic, but over the whole course of your career, all of the 3 or 4 years that you guys have had, what would you have wished you had learned that we didn't teach you, or what do you especially value in terms of what we taught you in your coursework and your other work at the Milken Institute School of Public Health that has helped to bring you forward? I know that's a really big question, but.
I honestly, and the reason I chose Milken was because of the ability to do the MS in public health and microbiology and the combination of science and of public health. And I think that's really been a great role in this, because we had to basically translate science data into something that's relevant in the epi side. And so I was just grateful to have a program that really provided both of them. And I think it depends what you're interested in. I personally loved also just like the SAS and R classes that we had to take, because for me, now that I'm putting data together, it's just, I know how to code, I know how to create basically something that's going to push public health forward and have an infrastructure that if this happens again, we can just reuse this, I can't really think of any flaws for Milken. I just loved it so much.
It's interesting, our president, because he's an engineer, he thinks Python is really cool, but I think R is cooler. I'm just Matt.
Yeah, and for me, I came in with a heavy laboratory background, but I really appreciated all of the epidemiology classes that I took, and it gave me, a better understanding of dealing with an outbreak and going through all of the the different calculations you can use, such as your attack rate and your R, and to see how an outbreak is transforming, and as it goes throughout the course of the outbreak. So having and using surveillance as a way to track that, both in the community as well as with specific populations. And I guess for me, the one thing that I sometimes wish I had was a class that, and this is very hard to do, but a class that prepares you for emergency planning, because we're in a stage where it's, we're planning stuff left and right, and it's it's not always easy to be flexible and switch to that. And I'm relying on all of the knowledge and the classes that I took at GW to get me through this, and it's been helpful. But if we had a class that also helped us with emergency planning, I think that would also be beneficial.
I just don't think any of us predicted such a big pandemic to happen in our lifetime. Like, I never knew I'd have so many concepts being implemented at one time.
Actually, I used to teach such a class in Hopkins, and I think in our humanitarian assistance program, we may have such a thing. So maybe bringing that in to your major, because there are tools, for doing planning around disasters, and how you do assessments on the fly, and it's really there is a field, but it's very different than kind of the routine kind of surveillance and tracking and lab work. It is very different, and so I think that's good input. I think that's a great idea.
Yeah, I think having the interdisciplinary knowledge of, you have your epi knowledge, you have your laboratory knowledge, and then we're now adding our emergency planning and response knowledge, and putting that all together makes us very unique in our abilities to respond to an outbreak, and it gives us a leg up on some of our colleagues that we're working with, because we understand the full global, like 30,000-foot view of what is happening and what needs to happen going forward. So I appreciate all of the classes I took there that helped me with that.
So one important aspect of crisis management is that you as a manager or a first responder, which you guys are, you're public health first responders, you don't want to become casualties. You don't want to be. So how are you taking care of yourselves? The equivalent of putting on your oxygen mask before you assist others, which is always good advice. But how are you able to take care of yourselves and to really week after week after week of being under what has to be an incredible amount of pressure?
Right. So we have our obviously our physical barriers we use when we're in the lab or on the field, our personal protective equipment. We have obviously our mask and our gloves and our lab coats or our gowns. We have our barriers of social distancing, and we perform risk assessments wherever we're going to look at that. But beyond that, as you're saying, I think it goes beyond that of keeping us healthy. We need to keep ourselves mentally healthy, emotionally healthy, and physically healthy. So beyond that, for me personally, it's exercise. So I exercise to get some of that stress out. It helps to clear the mind. I can think about how to attack a problem that I may be having at work, or how to plan for the next event that we're going to deal with, as well as sometimes you just have to let it go and take a break. Go with your family. I sit down with my wife and my son. We just watch a movie, and you just have to let it go, because you can't let it get to you. I could work 24 hours straight every day, and I still wouldn't finish all the work that I have to do. So at some point, you just have to let it go.
I would say mine would be Zoom meetings with my parents back home in California. I think a lot of my anxiety does, though, come from like, what do we have to do next? And I'm a planner. So what I try to do is, like, with my time off, other than running, I'll like sit down and try to figure out like priorities, just because we're so inundated with so much testing now that the doors are open. It's kind of just figuring out what needs to be done. So when I do go in the next day, I'm just prepared and mentally ready to handle what's going to come my way, which has been really hard because you don't know what you're going to get hit with every day, but planning to the best of the ability.
No, I think that's very wise. I've also found myself, when you've got crises that arise a lot, that it's really helpful to have every day a piece of the day where you're looking at the longer term, even if the longer term in this case is, where do I want things to go over the next week, so that you are not simply being buffeted back and forth from one crisis to the next, in which case you make no progress. So I think that's a good way to do it. If you think that way best in the evening, I think that way better in the morning. If I wake up earlier than everybody else, my brain seems to function better early in the day. But that's also something that you learn. But reserving that time is very important. And the physical activity, yes, absolutely. Spending time with your families. What we eat is important. That's a problem.
Yes.
Yes.
So, well, I think that I see one more question here from Dr. Hyder. If you had the choice to get one resource to help you, what would it be? If you had one more resource, that's really hard because there are probably about 20 things that you each need. But if there were one thing you need that you can't get now, just one.
Yeah, that's a difficult one.
For me, if I had just one resource, it would be someone to help with our, as you were saying, our electronic ability to send results back to people. So being able to send results on a phone. So I'd love to be able to do that. We just don't have the resources or the funding to build that into our current software system.
Yeah. I mean, it's really interesting because this pandemic kind of has resulted in just showing that we're not ready for like a supply chain. It like broke down. So now we're like depleted sampling kits. And so for me, I would want a lot more sampling kits to be able to be given to us, because a lot of these places, like I said, were places that were not ready for a pandemic, and we're trying to be able to give them the appropriate resources to test their patients in-house, whether it's the small group homes and places that don't have access to care. So kind of small little resource I would like, but I think it'd go a long way.
You know, in our own research at Milken Institute School of Public Health, our folks ended up having to actually manufacture reagents in the lab, you know, like viral buffering solutions and stuff like that. And they had to order swabs from 3D printing companies because of not even being able to order them, much less than feeling, well, if you had a way of getting them, you wouldn't want to take that supply chain away from public health, from, you know, critical care, you know, the other areas that couldn't get swabs at all, you know. And so I think you're right, you know, that even though we've had laws that create these stockpiles, that was supposed to do that. We were supposed to have these stockpiles that would be released to you guys when we had an emergency. And so it's kind of like we don't need a law, we need to implement the law so that it actually does what it's supposed to do. It's kind of been disappointing for many of us. So this is also a really hard question, and it's going to be the last one, looking at the time. But, and maybe you've already thought about this, and maybe not. But you know, if you were talking to prospective students or new students at the beginning of their career, you know, based on the experience that you've had, and the questioner wants it to be 3, it doesn't have to be 3, but what pieces of advice would you give to somebody who is thinking about, you know, following a career path like your career?
Okay.
She asked for 3 things.
I was waiting for a question similar to this, so I can go first.
Okay, good. Thank you, Matt.
And I would say,
so number 1 would be prepared. Yeah, go ahead.
No, I think for me personally, I would say don't be afraid of change, and don't be afraid to, you know, take a risk. So take a risk in following your heart to do whatever you want to do. And I take that from my experience of how I ended up in the public health lab was very unique fashion. So I was graduated, and then at GW, I was working in Dr. Jordan's lab, and I loved academia, but I always wanted to get into government. And I actually applied and got into a fellowship, the Capital City Fellowship, and worked more as a operations in the agency. So not for the public health lab, but actually the agency of Department of Forensic Sciences and I learned a whole bunch of new skills such as, accounting and budgeting and performance metrics and, all these skills that I didn't have, but I was able to pick up pretty quickly because it's, budgeting and accounting is very similar to doing statistics. So I was able to pick that up, and it gave me a greater, understanding of when I moved into the public health lab, when a position finally opened. I was able to apply those skills along with my EPI skills I learned at GW, my laboratory skills I've had from my previous education, and it allowed me to have better success. And so I would just say, I don't know if I have three things, but my main thing is just follow your heart and go where you think you should go, and don't be afraid of taking a risk. So you don't have to always plan something out and say, after I graduate, I have to get a job at this location, or I have to go to med school after this. Like, just be free and follow your heart and go to where you think you should go.
I liked your point about those management skills. I can't tell you how many times I've had discussions with students in the MPH, not the MS, that are taking a science track, and why do I need to learn anything about management? It's irrelevant, they think. And I'm like, well, how do you do science without being able to do a budget and manage people? You're gonna people working with you. We all need those skills at some level. So I think that's also a good point.
I'm going to kind of piggyback off of what Matt said. I think that this is an extremely exciting time to be in public health. It's devastating in a lot of ways, but I think this, beyond just being in public health, gives you an opportunity to be innovative and be able to kind of just go in whatever direction life kind of pulls you in, because I came into this position thinking I was going to just be doing normal surveillance, and I got pulled into this emergency response. And the amount that I've learned and the amount of skills I have gained to be able to go beyond public health now has been incredible. So if you even have a small passion for public health, I mean, you're not only helping people around you, this is like something global at this point. Like what we implement in the district can be given to the United States, going to a global. You just have all the means to make the change in the world right now. So if you want to do public health, I mean, I say you go for it, and really, it's going to be worth it.
Thank you both for that. I think a great parting message about following your heart and going for public health, and how important the work that both of you are doing is. To me, you're both heroes. You're on the front lines of this. And just in the way that our EMTs and our emergency room workers and our hospital workers are heroes. And I personally appreciate what you're doing. I know how hard you're working. I know how stressful it is every day. And at the same time, it's incredibly gratifying. You're making a huge difference in the world, and I thank you. I'm just proud to see our alumni who are doing so much to contribute to making this world a healthier place. Thank you so much.
Yeah.
Thank you. Thanks for having us.
Yeah.
Enjoyed it.
Bye-bye.
Bye. Thank you all.